It looks like we have a lot of people on the call. Thank you so much for joining. I'm Sarah Adams. I'm a GYN oncologist at the University of New Mexico, and I've worked with OCRA for a long time and really enjoy working with them and enjoy being part of this conference. I've been asked to talk again about ovarian cancer recurrence, and this talk from previous years is on the website, and I've got some updates this year that I'll highlight. And if it's okay with everyone, I'll take questions at the end because I just find it a little bit difficult to watch the chat while I'm talking. But we'll go ahead and get started. And please, if you have questions, please put them in the chat. And we'll go through those after the slides. And these are both Con paintings. I just think they're beautiful, and I stick them in there for the title slides to give us all something to look at as a break. Okay, here we go. Oh. It doesn't seem to be. Oh, there we go. Okay, so this is my disclosures slide. As I said, I have worked with the Ovarian Cancer Research Alliance for many years. I really enjoy working with them because I got my first research grant from this organization. So I'm deeply indebted to them and very appreciative of all of the initiatives that they've advanced over the intervening decade. I also have a clinical trial that's funded by AstraZeneca that I run, and I review grants for other foundations. Here's the outline of the talk today. We'll be talking about the likelihood that ovarian cancer might recur. We'll talk about symptoms that might be suggestive of recurrent disease and how we diagnose recurrence. And then we'll talk a lot about options for treatment and how people make decisions about what kind of treatment to consider. And we'll talk briefly about clinical trials, although I know there are other sessions specifically covering clinical trials. And then we'll have time for questions at the end. If I'm not being clear, please put that in the chat. Tracy said she would watch the chat, or if there's anything that I'm not explaining well, please let me know as we go. I included this slide to remember to say out loud that I know this is a really difficult topic, and I'll do my best to be as thorough as possible, but I just want to acknowledge that this can be a hard thing to talk about. And if you've heard my presentation in years past, a lot of this will sound familiar, but it might feel different depending on what's going on in your life and what kinds of treatments you might be experiencing. Okay, a couple other clarifications. Sorry, the slides are lagging just a little bit. Here we go. As many of you probably know, there are different kinds of ovarian cancer because there are different kinds of cells in the ovary. And I just want to clarify that most of the data I'll be sharing will be specifically developed in epithelial ovarian cancers. That's the most common kind of ovarian cancer. As you probably know, it arises from the surface of the ovary, and now we think probably also some of them come from the fallopian tube. There are ovarian cancers that can develop from germ cells, which are the egg cells in the ovary, but those are much less common, and so I won't specifically cover any data about them, but I'm happy to do my best if people have questions. And there are ovarian cancers that can come from the sex cord stromal cells, which are the cells that produce hormones in the ovary. Those are also quite a bit less common, and honestly, we use some of the same drugs for those cancers as for the epithelial cancers. I also wanted to clarify that there are different kinds of epithelial ovarian cancer, which you probably know. The most common kind is the serous ovarian cancers, and those make up the majority of the cases, and most of the clinical trials are dominated by patients with high-grade serous ovarian cancers. Those are the ones that people think now maybe probably come from the tube instead of starting from the ovary itself. But there's other kinds of epithelial cancers. There are endometrioid ovarian cancers. There are clear cell ovarian cancers, and there's some really interesting data now coming out from MD Anderson about clear cell ovarian cancers that we can talk about. And there are mucinous ovarian cancers. But since these are less common, there are fewer trials focused on them, and a lot of the same drugs are used across all of these cancer types. Also, just as basics to set the scene, as you probably know, most people with ovarian cancer undergo primary treatment with some combination of chemotherapy and surgery. Sometimes people get chemotherapy first and then surgery, which is called neoadjuvant chemotherapy. And sometimes people get surgery up front, followed by chemotherapy. And then people now more often are using ongoing treatment called maintenance treatment to extend the amount of time before cancer recurs. And the most common maintenance treatment regimens are Avastin or Bevacizumab, or using a PARP inhibitor. now mostly in patients with BRCA mutations in their tumors or in their germline. Sorry, I'm getting all the notifications as people are coming in the room, so they're popping up in my screen. I apologize for the interruptions. And then at some point, people often transition into a period of surveillance where they're coming in regularly for clinical visits to watch for any signs of recurrence and to evaluate for any changes in tumor markers or changes in their exam that might require additional imaging or follow-up procedures. And what we'll focus on today is what happens when a recurrence is diagnosed and what kinds of treatment options are available at that point. So here's another Wolf Kahn painting. I'll talk just briefly about the likelihood that ovarian cancer will recur, which is unfortunately quite common. So here's a fairly old figure from a publication illustrating the likelihood of cancer recurrence based on someone's initial stage at diagnosis. And you can see that higher stage disease is more likely to recur, but even people with early stage disease, and this is much less common, experience recurrence of their cancer after primary treatment. What's not illustrated by this figure is the amount of time before the cancer might come back, and that can really vary considerably. Sometimes people can go months or even years before the cancer comes back. Other times it comes back more quickly, depending on the efficacy of the treatment that people undergo. And so, as you probably know, there are some symptoms that we watch for that might be suggestive of recurrent disease. And some of these might sound familiar as campaigns were launched for a while to try to identify ovarian cancers earlier based on the presence of these symptoms. And that's because there was a big study surveying people who had ovarian cancer to ask them to recall what kinds of symptoms they had at the time of their diagnosis. And these are the most common symptoms that were listed, and they seem to be associated with the presence of ovarian cancer. And so these are the things that we ask people about at their surveillance visits. Most of them are symptoms associated with recurrent disease in the abdominal cavity and the peritoneal cavity, because that's usually where ovarian cancer comes back. And that includes bloating or abdominal fullness. Sometimes people can develop ascites fluid accumulation again, which can cause increased abdominal girth or trouble with digestion, bowel or bladder symptoms. Sometimes people have some pain associated with cancer recurrence. Sometimes people, although less common with ovarian cancer, can have vaginal discharge or bleeding or pain with intercourse. Sometimes people have lower extremity swelling if they have a tumor in their pelvis that's blocking fluid return. And sometimes people have shortness of breath or nausea or vomiting that might be associated with recurrence. Any of these things would be something to report to your treating provider. And I usually tell people, please call me with symptoms that persist for a week or two that you can't explain, and we'll bring you in sooner. I hate it when people wait to tell me at a scheduled appointment that they've been having symptoms for 2 or 3 weeks or even 2 or 3 months before the appointment. These would be important things to notify your provider about, and you can decide together whether it merits additional workup or follow-up. When people come in for a surveillance visit or when they come in with symptoms, we perform physical exams, and we're looking for any evidence of disease recurrence in the places where we know ovarian cancer is likely to show up again. And that includes feeling lymph nodes for any swelling or firmness that might suggest tumor involvement. We listen to people's chest for evidence of fluid accumulation around the lungs. We do abdominal exams looking for tenderness or fullness. Sometimes we can palpate nodularity or masses. We subject people to pelvic exams because it allows us to feel the surfaces in the pelvic cavity and to feel for any evidence of tumor nodules in the pelvis, which is very convenient as a way of evaluating for symptoms associated with recurrence. And that's why we put people through these exams routinely. And then we look for swelling in the legs or other changes in people's status. But a lot of people who have cancer recurrence or ovarian cancer recurrence specifically may be asymptomatic. And that's because oftentimes the cancer recurs in the peritoneal cavity and maybe isn't accessible on exam to find it or feel it. And so we will also evaluate people with tumor markers. And so you're probably familiar with CA-125, which is a fairly frustrating tumor marker that doesn't work very well for screening or diagnosis, but it is quite effective in helping us track people's response to treatment and help us identify possible recurrence with changes in the CA-125 level. And what I think is important to understand about CA-125, which is extremely frustrating from a clinical standpoint, is that it's almost like different people have different thermostats. Patients I've taken care of sometimes have very subtle changes in their CA-125 that can be associated with cancer recurrence on imaging studies. Other people's CA-125 jumps by hundreds of points with very little change on their CT scan. And so I tend to use this in my practice as a first step for evaluation for possible recurrence. And if there are changes in CA-125, we'll follow up with imaging studies. And usually we make decisions about treatment based on what's on the imaging study, not simply based on the CA-125, although sometimes that's all we find. As I said, we usually use CT scans to look for recurrence. In some cases, people might recommend MRIs instead. And sometimes people use PET scans, although I think that's maybe less common with ovarian cancer than it is with other tumor types. And the reason for that is that, as you know, PET scans use a tracer dye that can be taken up by tumor cells more rapidly than by healthy cells. And so it shows areas of metabolic hyperactivity, basically. But this can sometimes be confused with inflammation because areas of inflammation are also metabolically active. And usually with ovarian cancer, we can see what we need to see on a regular CT scan without that added information. Sometimes it can be a little bit confounding if people have infections or other reasons why they might have inflammation nearby. So I tend to use CT scans most of the time, but there's some variation in practice with imaging studies. Okay, so now that we've sort of set the scene for what we do about recurrence, we'll talk through some different options for managing ovarian cancer recurrence. And this will go through treatment goals as well as different approaches to cancer treatment. As you probably know, the goals for treating recurrent disease are primarily to extend people's disease-free time and their overall survival. But we're also trying to be very attentive to quality of life and management of symptoms. And sometimes that can be a balance depending on where someone's cancer has recurred and what kind of symptoms it's causing, and also depending on how much treatment she's had before and what the likelihood is of success with a new treatment regimen. And so this typically involves a discussion about goals of care, symptoms, expected side effects associated with treatment, to come to a decision together about the best way forward. But what I hope I'll convey during this talk today is that there are a lot of options, and sometimes it's helpful to know that there may be other options to consider when you're thinking about treatment for recurrent disease. Broadly, the options include surgery, chemotherapy. We'll talk about targeted therapeutics. We'll talk a little bit about immune therapy, which isn't specifically approved for ovarian cancer, but there's more and more evidence of possible applications for ovarian cancer. Hormone therapy, the role of radiation treatment in ovarian cancer. And then, as I said, we'll talk about clinical trials, observation, and best supportive care. So it used to be that people had surgery when they were first diagnosed and didn't typically undergo surgery again for the management of their ovarian cancer. But now there's more and more evidence that in certain situations, consideration of surgery again may be helpful and may extend someone's progression-free and overall survival. And typically, the use of surgery in recurrent disease is reserved for people who have better prognostic features, like they've had a longer amount of time since they finished treatment for their cancer previously, or they have limited sites of recurrence that can be accessed surgically. Usually this is reserved for people who still have platinum-sensitive disease, who are expected to benefit from chemotherapy after surgery, and people who have what we call good performance status, which means they don't have other medical conditions or comorbidities that would increase the risk of surgery. Just like with frontline debulking surgery, the goal with debulking surgery in the recurrent setting is to remove all visible disease. And so a lot of these features that I've just listed are indicators of the likelihood that we'll be able to optimally cytoreduce somebody. And we try to predict that the best we can before taking someone to the operating room. Since we're finding recurrent disease sooner when it's smaller, there are now minimally invasive options, which means laparoscopy or robotic surgery that can limit the morbidity associated with surgery in the recurrent setting, get people out of the hospital faster, and hopefully get them back to chemotherapy again sooner. So there's less of a gap in treatment during the time that they're undergoing surgery. And then just to clarify, sometimes people will have surgery specifically to palliate symptoms. For example, if someone has a bowel obstruction, she might undergo a diverting colostomy, and that's to relieve the symptoms of the bowel obstruction. Those goals are different than the goals of cancer treatment for recurrent disease. The mainstay of treatment for recurrence is chemotherapy again. And decisions about which chemotherapy regimen to use are usually based on how long it's been since someone's been exposed to chemotherapy treatment in the past. And as you probably know, we divide ovarian cancer in the recurrent setting into platinum sensitive and platinum resistant categories. And this, I just want to clarify, is not because something happens after 6 months, it changes the tumor. It's just a way of dividing what we observe into two different groups to help us make decisions about treatment recommendations. And so usually someone's considered platinum sensitive if it's been more than 6 months since she's received a platinum-based chemotherapy agent, and platinum resistant if it's been less than 6 months. But you can see that sometimes people report the treatment-free interval at 12-month intervals. And essentially, the longer it's been since someone's had chemotherapy treatment, the better they're likely to do with repeat treatment. Here are those definitions of platinum resistance and platinum sensitive disease based on the 6-month dividing time since the last exposure to platinum chemotherapy, and how those categorizations help us make recommendations about treatment. Usually, if it's been more than 6 months since someone's had a platinum drug, we will recommend retreatment with a platinum combination, as long as there's no concern about hypersensitivity or drug reactions. Whereas if someone recurs within 6 months of prior platinum treatment, we usually recommend other kinds of chemotherapy agents. And platinum refractory disease usually describes cancer that grows in spite of treatment with a platinum agent. And the prognosis associated with that is generally more limited than with the other two categories. Here are some examples, and these come from a review that's now a little bit old. It's from 2013, but it's helpful, I think, to see the difference between the kinds of responses we expect in the platinum-sensitive recurrent setting and the platinum, I don't remember if I just said sensitive or recurrent, but the other one. These are platinum-sensitive trials, and you can see that the likelihood that someone's going to benefit from treatment, which is called the response rate, is generally high, and it's higher if more than one drug is used with the platinum agent. So carboplatin and Taxol, carboplatin and Doxil. These all tend to be very effective combinations in platinum-sensitive recurrent disease. And you can see that the expected time until the cancer comes back after treatment is about a year, which is better and better with more recent trials as newer agents have been developed, and set some expectations for patients and for providers about what benefit you might be able to anticipate with treatment in the setting of platinum-sensitive recurrence. In platinum-resistant disease, which usually includes people who've had multiple recurrences, we don't use platinum agents again, typically. We use other chemotherapy regimens, and some of those drugs are listed here on the left: Doxil, topotecan, Taxol, Avastin. And you can see that the response rates are generally lower than they are in the platinum-sensitive setting. And in these cases, there's, I think, more attention paid to possible side effects and the effects of treatment on quality of life, and trying to balance improved outcome without causing people new symptoms that will diminish their quality of life or restrict their activities. And you can see that the most common side effect is myelosuppression, which is bone marrow toxicity that results in drops in people's blood counts. Most commonly, they're white blood cells, which are the ones, as you know, that fight infection. Sometimes platelet levels drop, which limits our ability to keep treating them with these regimens. There are other kinds of treatment categories, though, and there's been some really exciting advances in these different types of treatments. So we'll talk a little bit about targeted agents, and there's just recently been a new FDA approval for a combination of targeted therapy for low-grade serous ovarian cancer that's worth celebrating because it's just nice to have more options, and it's nice to have additional regimens, specifically in low-grade serous cancers. Avastin is considered a targeted agent. Avastin, as you probably know, is an antibody that's designed to block new blood vessel growth. So we'll talk about antibodies again in a minute when we talk about antibody drug conjugates. But antibodies are proteins produced by your immune cells, usually to fight infection. But pharmaceutical companies have taken advantage of the specificity of the antibody component that binds its target and use that to create medications that bind targets to block signaling in ways that can be very helpful for cancer prevention or cancer treatment. And so Avastin is an antibody that blocks something called vascular endothelial growth factor, which is responsible for generating new blood vessel growth. And so essentially it kind of starves the tumor by not allowing it to recruit new blood vessels to provide nutrients and oxygen that help it grow. And Avastin has been incredibly successful in ovarian cancer, both as a single agent, either in the maintenance setting or in the treatment setting, but also as we saw in combination with chemotherapeutics to increase the likelihood of tumor regression and to prolong the time before people see cancer recurrence. I think everybody's probably heard about PARP inhibitors. They have been a newer agent that have substantially changed outcomes for people with ovarian cancer, especially people whose tumors have defects in the DNA repair pathways with BRCA1 and BRCA2. And you know that some people have inherited mutations in these pathways that may increase their risk of developing ovarian cancer, but it also increases the likelihood that a PARP inhibitor will be effective for them as maintenance treatment after chemotherapy. And other people might have mutations in these pathways just in the tumor itself. And so now we will test people for hereditary BRCA mutations, which are called germline mutations. And we'll also test the tumor to make sure we're not missing an opportunity to exploit these genomic patterns with the treatments that we have, like PARP inhibitors. And then finally, antibody drug conjugates have been one of the most exciting stories in ovarian cancer over the last couple of years. These are targeted agents that use the targeted part of an antibody to drive chemotherapy molecules directly to tumor sites. And I have a slide about this, so I'll wait and we'll talk about it again in just a minute. But first, under targeted therapies, I have this new FDA approval, which is wonderful news for people with low-grade serous ovarian cancer, specifically associated with a KRAS mutation, which is a common mutation in these kinds of low-grade tumors. This is for a combination of two targeted agents, and it's really interesting and, in my opinion, exciting because the investigators who developed this combination recognize that blocking one signaling pathway might be effective, but tumor cells can be smart and they upregulate a second pathway. And so by blocking both at the same time, they were able to achieve better response rates and longer lasting treatment effects in people with these low-grade recurrent ovarian cancers. And so you can see in these figures, these are survival curves on the left at the top that show the proportion of people on the y-axis and time on the x-axis. And this is showing how long before people see their tumors recur. And in this case, it's been divided in this trial based on the presence or absence of the KRAS mutation. And what they're showing is that people who have the KRAS mutation, which is in that sort of dark blue color at the top, have longer time before they see their cancer recur and seem to have more benefit from this particular combination, which is what led the FDA to approve this specifically for people with this mutational profile. And the figure on the bottom is called a waterfall plot. What it shows is how much the tumor has grown or shrunk during the clinical trial testing this combination. And so the bars that go up represent tumor growth, and the bars that go down represent tumor shrinkage. And you can see again that the people with KRAS mutations in the dark blue are heavily represented among the people whose tumors got smaller. And this is why this recommendation is specifying the KRAS mutational status. The response rate was 44% in people with a KRAS mutation and 17% of people without that mutation. And so this is one of the first FDA-approved combinations in quite a while. And as I said, represents a really exciting opportunity for people specifically with this low-grade serous cancer. Here's the antibody drug conjugate slide. Maybe a lot of people have heard about these, and maybe some of you have been treated with antibody drug conjugates. I think they're really exciting for a lot of reasons, but one of them is the way that they were developed. So shown at the top, I don't know if you can see my pointer, but this kind of Y-shaped molecule up here is an illustration of an antibody. And these are remember, the proteins that your immune cells make to fight infection. The way they work is that top of the Y is the part that recognizes a target. And usually the stem of the Y stimulates immune cells to help fight infection. But for the antibody drug conjugates, the companies that have developed these have substituted a chemotherapy drug for that stem of the Y. So essentially you have a highly specific targeting protein connected to a chemotherapy drug. And so that targeting protein goes to where that target is expressed, in this case to the tumor, and brings the chemotherapy with it. And what this is intended to do is to concentrate the chemotherapy at the tumor sites where we need it to be, and to limit the effects of chemotherapy at other sites, like in the bone marrow or in your healthy cells, to try to reduce the likelihood of side effects associated with typical ways of giving chemotherapy through the IV, and really increase the effectiveness at tumor sites. This has been incredibly successful in platinum-resistant ovarian cancer, which was especially exciting because we need more options in platinum-resistant disease. And I've shown some of the data here. This mirvetuximab drug, which targets the folate receptor alpha, had a 35% response rate in platinum-resistant disease, which is better than some of the chemotherapy regimens that we've been using for a long time. And there are more and more antibody drug conjugates becoming available and being tested in clinical trials. Most of them are unpronounceable, but here are the targets shown here. HER2 is one of the more pronounceable targets, and trastuzumab is one of the more pronounceable antibody drug conjugates. But these are now being moved into the platinum-sensitive recurrent setting, given how effective they've been in the setting of chemotherapy resistance. And there's a lot of interest in trying to decide how to sequence these drugs. For example, if someone is treated with one antibody drug conjugate and their tumor develops resistance, should we use a different antibody drug conjugate with the same target, just a different chemotherapy drug attached to it? Or should we change the target and then just use whatever chemotherapy had been effective along the way? And this is an area of active investigation by national cooperative groups. And more trials now are considering whether somebody's previously been treated with an antibody drug conjugate in their eligibility criteria, so that we can address questions about how to sequence them and whether people continue to have benefit if they've already had one of these, if they're treated with another one, either with a different target or a different, it's called payload, the chemotherapy drug. I'll talk briefly about immune therapy. Unfortunately, most immune therapy has not been specifically approved for ovarian cancer, but there are many, many, many trials and a lot of ongoing research investigating the role for immune therapy in ovarian cancer. And I think this is very exciting, and I hope it will be more available soon. The short story is that the goal of immune therapy is to elicit an immune response against the cancer. And this is particularly interesting in ovarian cancer because ovarian cancer is one of the first cancers where we identified a relationship between spontaneous anti-tumor immunity and people's long-term survival. Specifically, it turns out that a lot of people already have evidence of an immune response to their cancer, and those people tend to have longer survival times. And so the idea is that if you could elicit a response in people who aren't generating one on their own, or amplify that response, we might be able to improve outcomes for people with ovarian cancer. And some examples of immune therapy include cancer vaccines. T cell therapies, and then immune checkpoint inhibitors, which have been adopted in the treatment of many other cancer types and have been included in clinical trials for ovarian cancer. And this is what I show the medical students to explain immune therapy. So forgive me, but this is a cartoon. It shows an an antigen presenting cell, this thing that looks like a starfish on the left. These are the cells that pick up, bits of debris, cell debris, or foreign invading bacteria or whatever. They're kind of the scavengers that pick up whatever they find that is not supposed to be there in your body. And they take those bits of cells and proteins and things to the lymph nodes to show them to T cells. And that often generates a T cell response. T cells are the immune cells that fight infection and fight cancer. And the T cells then travel to the site of infection or to the tumor itself. And in the case of the tumor, hopefully they kill tumor cells. And so the analogy I use with the medical students is like middle school, right? Because everybody's been to middle school. So the antigen presenting cells are like the informers. They're the ones who are traveling around trying to see what's going on, and they tell the T cells what's up. And the T cells are like the enforcers. They go out and take care of whatever needs to be taken care of. And I say this every year, but I can't bring myself to label this little kid as a tumor, but you get the idea about the T cell role. And so what immune therapy does is it tries to amplify that response, either by increasing the amount of information provided to antigen-presenting cells, and that can be done with a vaccine that shows antigen-presenting cells tumor antigens, or sometimes by just infusing people with antigen-presenting cells that already have tumor antigens in them so they can provide that information to the T cells, or by skipping that step entirely and just infusing people with T cells. And this is T cell therapy. You may have heard about CAR T cells or TIL therapy. Those are all ways to increase the number of T cells that recognize tumor so that they can hopefully clear the tumor and even better, induce a memory response so that if the cancer starts to come back, your body will be educated, your immune system will be educated to prevent recurrence. As I said, currently these are not specifically approved for ovarian cancer, but there have been phase 2 trials of many of these strategies and some specific examples of cases where immune checkpoint inhibitors might be used in ovarian cancer. So I hope that by the time we give this talk again next year, we'll have some updates about immune therapy for ovarian cancer. As we review, these are the goals: are to elicit or boost an anti-tumor immune response, to induce memory, which is really the wish with immune therapy, is to teach the immune system to recognize recurrence so it can control disease long term. And there's a lot of interest currently in ovarian cancer and other cancer types, combining this approach with chemotherapy and with some of the targeted therapies that we've talked about. All right, we're almost through this chapter. I'll talk briefly about hormone therapy. This is something that is incredibly effective in low-grade serous ovarian cancers, and there's now a clinical trial that's ongoing, led by my colleague Amanda Nichols-Fader, to ask the question whether we can even skip chemotherapy in patients with low-grade serous cancers and go directly to hormone therapy because it appears to be so effective. That trial is ongoing, and we hope to have the results soon. But this approach to treatment has also been used in high-grade ovarian cancer recurrences if the cancer expresses hormone receptors. And in my practice, it, I think, presents an opportunity to try to hold the cancer at bay and maybe take a break from some of the side effects of chemotherapy. And the reason I say this is that for most people with ovarian cancer, hormone therapy doesn't really make the cancer shrink, but it does do a pretty good job of maintaining stable disease, at least for a period of time. And sometimes that just allows people to recover from all the effects of the chemotherapy they've had before they start another chemotherapy regimen. Many of these hormone therapies are also oral agents, which can be nice to avoid coming in for IV infusions, and again, help people just have a pause and a time to recover from the effects of other kinds of treatment. But in certain situations, this can be highly effective, and specifically, as we mentioned, with low-grade serous cancers. People ask me sometimes about radiation treatment. I'll just say that radiation is very effective for ovarian cancer. But the problem with radiation treatment is that where ovarian cancer tends to recur is an area that can um, be very sensitive to radiation. So specifically, ovarian cancer tends to come back in the abdominal cavity. It tends to come back at multiple sites. And it's very difficult to subject somebody to radiation treatment of their abdominal cavity without causing injury to the bowel or toxicity associated with that. And so we're more likely to use radiation treatment for people with recurrent ovarian cancer if they have, for example, an isolated tumor in their lungs or in another place it's a little bit easier to target with radiation. But usually this is not the first line choice for recurrent ovarian cancer. And then lastly, I put in these slides to force myself to talk about what happens if you decide not to start treatment right away. And I try to remember this in my own practice, and I'm going to show you the trial that changed my thinking about this. In general, most people think it's important to treat recurrent disease early while the recurrent tumors are small and likely to be more sensitive to treatment. And also before people are symptomatic from their disease so that you're not trying to manage side effects as well as tumor-induced symptoms like pain or changes in bowel habits or things like that. And so trying to keep the cancer small so that people can have less effect on their quality of life is an important goal. However, there's a group from Europe that asked this question. Now it's been 15 years. It's been quite a while. But their question was whether early treatment of recurrence improved survival, which is an important question. And the way they approached this was to recruit people with ovarian cancer and monitor their CA-125, which is the tumor marker we talked about earlier. And once their CA-125 doubled, which is associated with a high likelihood of recurrence, they randomized them into two groups. One group of people was alerted to the fact that their CA-125 had doubled, and they started treatment. They got CT scans and worked up and started treatment for recurrent disease. The other group of people were not told that their CA-125 had gone up. So they only started treatment for recurrent disease once they had symptoms or findings on their exam or imaging studies that indicated that they had recurrence. And the idea here was that this would probably be a group of people who were treated earlier and then maybe later in these two groups, and they were monitored for length of survival and quality of life. And the reason this was so striking to me was that there was absolutely no difference in overall survival in these two groups. And this felt surprising at the time because we all use CA-125 as a way of screening for cancer recurrence. And we all hope that treating recurrence early is going to benefit people long term. Now, there's a lot of caveats to this study. Most importantly, that this was 15 years ago, and I've just told you about a bunch of new treatment options that have become available since then. But it helps me remember that sometimes we might have an opportunity to take a little bit of a longer pause between chemotherapy regimens. And so in my practice, sometimes if people are asymptomatic and their CA-125 goes up and we get a CT scan and see small volume disease, we might talk about whether to just look again in a shorter interval, like after 2 months or 3 months instead of waiting longer, to see if that disease is largely stable or quiet, and we can postpone chemotherapy for a little bit longer. Or if there's a change in that short period of time, we would start chemotherapy. Some people are comfortable with that. Some people really don't like knowing that there's something there that we're not managing. But I feel like sometimes it allows us to stretch out the time between chemotherapy regimens, kind of as a way of playing the long game and making the most of the options that we have for treatment, as well as prolonging the time when people aren't dealing with treatment-related side effects. So I bring it up here just as a possible consideration to talk to your provider about if you end up having a discussion about treatment for recurrent disease. It might be helpful to ask or to talk about what happens if we postpone treatment, or what happens if we keep a close eye on things and make a decision at the next CT scan. Okay, I'm almost done, Tracy. Let's see. I'm going to talk about clinical trials, knowing that there's I believe another session in the conference specifically dedicated to clinical trials. But I think this is an important thing to consider when you're thinking about treatment options. And in my opinion, there are features of clinical trials that are important to understand to help you make a decision about whether this is something that would be right for you. So just as basic explanations, standard healthcare is what we do all the time with the drugs that are available to us to prescribe, the chemotherapy drugs that are approved, all of the things that we've just discussed. Whereas research is an activity designed to test a hypothesis, and in clinical practice, it's testing a new approach to treatment to see whether it's safe and whether it's effective, and then whether it's better than what we've already been offering people. And so there's two goals with a clinical trial. It's treatment of the person as well as generating knowledge to help us inform treatment of people more broadly. And so this process, of course, requires a lot of oversight, regulatory oversight and safety oversight, and their ethical considerations. And most important, in my opinion, is that this is always a voluntary process. So anytime you're considering a clinical trial, you will be asked to sign an informed consent, but it's important to know that you can always withdraw consent, that it's not binding, that this is 100% voluntary. And hopefully your provider will assure you that your cancer will be, that they will manage your cancer whether or not you choose to participate in a trial. What can be, or at least the way I think about clinical trials, is it's helpful for me to have more things to offer somebody, and it may be helpful for a person to have more choices of treatment that might include clinical trials. And so that gives me the standard treatment options to discuss with someone, as well as potentially additional options with the trials. And having more choices, I feel like, is always a helpful thing to consider. Some features of clinical trials that come up in questions a lot are randomization, which some people are more or less comfortable with. In order to decide or to really be able to tell that a particular treatment is better than a control regimen, and usually the control regimen is standard of care chemotherapy, and the experimental group will very likely be chemotherapy plus a new drug, patients are randomized. Subjects in the trial are randomized. And sometimes you know which treatment arm you're randomized to, and sometimes you don't. And that's the process of blinding. And the reason that's done is to reduce the risk of bias, both on the part of the provider treating the individual and potentially on the part of the individual and their interpretation of their symptoms. But some people find that very uncomfortable, and some people are okay with it. And so it's an important feature of the trial to discuss with your provider and to consider if you're thinking about enrolling in a trial. In general, phase 1 trials are designed to test novel treatments to make sure they're safe. And so the primary goal of a phase 1 trial is not whether the drug works to shrink the cancer, it's whether the drug is tolerable so that we can establish a dose that can be moved forward to a phase 2 trial to test for efficacy. These are usually very small trials. They might have 15 or 20 people in them. They are not blinded. They typically don't have a control group. Everybody gets the experimental drug. They just might get it at different doses, and there's no randomization in these trials. Once a dose is established, agents are moved to phase 2 trials, which are looking for specific evidence of efficacy in a cancer type. Phase 1 trials might include people with lots of different kinds of cancer, but phase 2 trials are usually focused on one kind of cancer, like ovarian cancer. Depending on how the drug is developed and how the trials advance, these could be smaller randomized trials, or they might be single-arm trials where everybody gets the same treatment. And so they may or may not be randomized, and they may or may not be blinded. And this is something to ask about if you're considering one of these trials. If there's good evidence of efficacy, things move forward to a phase 3 trial. And these are huge trials, hundreds of people, typically conducted across the country. And the goal here is to compare a new treatment regimen to what we're all using already in most cases. And so there is a control group, but the control group in cancer trials is not withholding treatment. It's giving people, for example, carbo and Taxol, and the experimental group gets carbotaxol and the experimental drug. So everybody's getting cancer treatment. The question is whether the new drug has added benefit on top of what we're already doing. These are the studies that are often blinded and randomized. However, these are also studies where there's been enough evidence of efficacy in a phase 2 trial to justify a huge, expensive phase 3 registration trial. And so I hope that that can be potentially reassuring for people who are considering these trials. First of all, that you're going to get at least the standard of care. And second of all, that whatever is being tested is exciting enough to challenge standard of care. And so whichever arm you end up in, there's an expectation of individual clinical benefit. And lastly, you might hear about something called phase 4 trials. These aren't really trials in the same sense. They're not a group of people who recruited and consented. It's more like post-marketing surveillance to look for new safety signals that might not have been captured in the clinical trials that were run before. And sometimes that can change recommendations about treatment, like some of the changes in the way that PARP inhibitors have been approved recently, based on volume of data that's come in when these drugs are introduced to clinical practice. In my opinion, there are advantages to all of these different kinds of clinical research. Phase 1 trials will give you access to the newest cutting-edge drugs that are emerging from science, from the lab. However, there is no data about whether they work in people yet. So some people are comfortable with that uncertainty and excited about the thought of getting the newest drugs available. Some people are less comfortable not having evidence of safety and efficacy in other people first. These are smaller, as I said, they're usually not randomized or blinded, and these trial results tend to come out faster because they're smaller trials. Whereas phase 2 and phase 3 trials, as we just talked about, are looking at efficacy and even challenging standard of care. And so those are huge trials. We might not have results for a couple of years, but there's enough evidence of benefit that the companies and sometimes the NCI has invested in these big national trials to really learn more about these regimens. And so there's a lot of reasons to be hopeful that these will be effective for an individual as well as more broadly for us in the field. So just to repeat what I've already said, I think the biggest benefit of clinical trials is just having more to offer people and more choices for management of recurrent disease. But there are also additional benefits of participation in a trial, which are that your care is being overseen by a huge team of people, both the individual provider as well as the clinical trial team. And this, for national trials, includes national expertise in ovarian cancer treatment. And then, of course, there's the altruistic component of clinical research participation, which is that we hope that we're generating new knowledge that will help other people with ovarian cancer to increase the number of treatments that we have available for people moving forward. And so there are a lot of questions you might consider asking. I would strongly encourage you to ask any questions you have. As I said, this is voluntary. We deeply appreciate people's participation in trials that allow us to move the science forward, but it's important to balance your own treatment history and your previous experience with treatment with the expected side effects associated with an experimental regimen and your comfort level with the uncertainty associated with clinical research. And you should expect that your provider and the clinical research team will be able to answer any questions you have upfront or as the trial progresses, based on your experience in the protocol. So I left this slide in because I'm so happy that what was emerging last year is now actually approved. We have antibody drug conjugates available. We have new targeted therapies, and I hope we'll have some immune therapeutic regimens on the horizon. And so in summary, I want to emphasize that there are many options available for the management of recurrent ovarian cancer. I feel very hopeful. There have been some really exciting developments over the last couple of years and ways of treating cancer that are sort of a whole different approach. Antibody drug conjugates are a whole different thing than old school chemotherapy, and immune therapy is a completely different paradigm for cancer treatment. And so I feel very hopeful about our ability to control recurrent disease and to sustain people and maintain their quality of life through treatment. As I said, these are the goals of treatment for recurrent disease, and there's a lot of information available on OCRA's website, as well as other sources of medical information. And it looks like there's already 50 questions in the chat, so I'll do my best to answer as many of these as I can. I don't know, Tracy, if you were able to look through and see if there's a theme or some top hits that I should address first or prioritize.
There are many themes.
Okay, all right. All right.
Why don't I, what, and some of the questions, although there are 50 questions, they're repeated. So
Okay.
that'll help as well. I
Okay.
think one of the questions that's come up is about scans.
Yeah.
Um, One doctor will recommend a CT, one will recommend an MRI. What's the role of PET? And then some feedback around the CT was clear, and 6 months later there was a large progression of disease, and does that mean that the CT is not reliable? So a lot of feeling around what's the best option for scans. Do
It's
you have
so
any
hard and
thoughts?
it can be so frustrating. Yes, I have a lot of thoughts and I share the frustration there. Let me start with the different types of scans. As we talked about briefly, some kinds of scans are more helpful for certain questions that people have. For example, MRIs are really helpful for distinguishing soft tissue density masses. Um, and so there might be a reason why a provider recommends an MRI instead of a CT, depending on what they're looking for. Sometimes people don't get MRIs because they're claustrophobic and they just don't like to lie in the MRI scanner, which can be a little bit uncomfortable if you're claustrophobic. The question about PET scan and CT is one that comes up, I think, more often, and that's what I was trying to explain earlier, is that the PET scan has added information about the metabolic activity of tumors that might be detected. In general, with ovarian cancer, I think we're able to see what we need to see with a regular CT scan. We can see tumor implants in most cases, and sometimes the PET scan can be confusing if you're not able to tell if area of brightness is tumor or inflammation.
Mhm.
I tend to use PET scans more often in people who've had radiation before because sometimes an irradiated tumor is kind of like a scarred fibrotic tumor site that doesn't go away completely, but it's not active. And so having that extra information about whether it's metabolically active is helpful in those cases. But I don't tend to use in my practice PET scans very often for ovarian cancer. Other people find that extra information very helpful. So I think it's a provider difference. The question about, man, you had a clean scan and then 6 months later things look different is so frustrating, and I don't have a good answer for that. I have personally operated on somebody, I performed a surgery on somebody for benign reasons who 6 months later had widespread ovarian cancer. So even surgical experience, and direct access to somebody's abdominal cavity did not provide any clue that she would show up with ovarian cancer 6 months later. And so the way I understand this is that this cancer just sometimes grows really fast. I don't know why. I don't know what triggers the recurrence. There's some interesting information about people's immune status. And for example, people who have autoimmune conditions, correlations between their inflammatory markers and cancer recurrence. But I think in general, we don't fully understand what makes the cancer come back and where it's been hiding when it hasn't been detectable. And then the last thing I'll say is that sometimes it can be very frustrating because somebody's CA-125 rises, but you can't find something on CT scan. And I think this is maybe more common with the use of maintenance treatment and specifically Avastin, where you don't see tumors big enough to detect on a CT scan, but there's probably carcinomatosis, which are those little tiny tumor implants that we can see at surgery, but we don't easily see on CT scan. And so deciding whether to respond to that situation with chemotherapy early based on the CA-125, which is called a biochemical recurrence, or whether to wait until there's something that's detectable on a scan is a decision to talk about with your provider. People can be very frustrated because they might not qualify for a clinical trial because they don't have enough tumor to qualify, which is probably the best reason ever not to qualify. But knowing something's there and not being able to enroll in a trial to address it can also be difficult. Um, so I don't have a good answer except to say that sometimes it depends on the situation and a particular person's um, tumor recurrence patterns and her treatment history.
Thank you.
Yeah,
Thank you. One of the other questions that came up early was, can a tumor change subtype upon recurrence?
not usually. So sometimes you'll read about, for example, borderline tumors, which are non-invasive ovarian cancers, essentially, that we don't treat with chemotherapy because they don't respond well to chemotherapy, and that's because they're so indolent. Sometimes those can dedifferentiate and show features of invasion or of frank cancer. But And sometimes people can have mixed histology cancers where they have like a clear cell component inside of their cancer, and sometimes that's what is more aggressive and comes back. So the recurrence might be primarily the clear cell component, but usually the cancers don't switch between types so much, and they definitely don't switch between epithelial and stromal, things like that.
Thank you.
Mhm.
Um, we had a question about carbo allergy. If you've had a
Yeah.
carbo allergic reaction, should you try it again 2 years later?
Usually when people develop a reaction to, so it can be frustrating also. So when people have a reaction to Taxol, it's usually an immediate allergic reaction, a hypersensitivity reaction with cycle one. With carboplatin and platinum agents, it's something that develops over time, and it's most common to see after someone's had 8 cycles of carbo. So it's usually when they've gotten through frontline treatment, things have been good, they've been on maintenance or whatever, and it's when they have a recurrence and start carboplatin again that they develop symptoms of carboplatin sensitivity. Uh, that doesn't seem to go away if you stop carbo and re-expose somebody to it. Usually the way it's managed is by using a desensitization protocol, which is administering chemotherapy very, very slowly. Sometimes people are brought in as an inpatient because it takes so long to deliver the chemo. We give it at 1/1000th of the dose and then 1/100th, which is very slowly drip it in. Whether that's worth it and whether there might be other drugs that would be effective or worth considering is a discussion to have with your provider based on how severe your reaction was and where you are in treatment for your recurrence.
Thank you.
Yeah.
There was a question if someone has ovarian cancer and has PD-L1 plus, are they eligible for Keytruda?
No, not currently, but you have to have MMRD officially to be eligible for Keytruda. But there's some really exciting data, in my opinion, coming out of MD Anderson about response to immune checkpoint inhibitors. Keytruda is an immune checkpoint inhibitor. These antibodies that block inhibitory signals to immune cells. Anyway, the data was evaluating responses in people with clear cell ovarian cancer, which is generally difficult to treat with chemotherapy. It tends to be less sensitive to chemotherapy than serous cancers. But what the investigators at Anderson, and it's Dr. Amir Desiri and his team, showed was that there was longer overall survival in people with clear cell cancer enrolled in these trials who got immune therapy. And they did a lot of work to investigate the mechanisms about why this might be. And their data adds to accumulating evidence that maybe this particular kind of ovarian cancer would be a good target for immune therapy. So in my practice, I've petitioned insurance companies sometimes to try to get immune therapy for clear cell cancers.
Thank you. I'm sorry, I think we have time for only one more question.
Oh, I'm sorry, everybody.
No, 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 but I'm so there's a lot of appreciation in the chat for how thorough your talk has been, and as always, we're so greatly appreciative. One quick question, like a timing for um, at recurrence to retest tumor or for biomarkers. Do you have a standard on that? Will there be a different mutation sometimes?
I'm sorry, Tracy. Tell me that again.
Sorry, when showing a different mutation in recurrence, like how do you know? Does that
Oh, should we
happen?
re-biopsy people
Should
to
you
look for? Okay,
rebiopsy?
got it.
Should there, I'm
Yeah.
sorry.
Yeah. So I don't know his answer. So a lot of clinical trials are asking for tumor biopsies, especially if they're looking at targeted agents like those antibody drug conjugates. The question about whether to rebiopsy somebody to evaluate eligibility for an antibody drug conjugate, I think is a really interesting question because while they're specifically designed to be targeted, there's some evidence that efficacy might not be directly related to expression of the target. And that's an active area of investigation. And there are some trials now that are enrolling people with high and low levels of the target, kind of looking at whether we can find benefit in a broader population of people who might have been considered negative, but really they have some expression of the target. And the thought is that this is a bystander effect where the antibody drug conjugate targets the tumor cells that do express the target, and then the chemotherapy molecules released and can affect neighbors and have benefit more broadly than we thought. So I think we all use archive tumor if it tells us what we want it to tell us, that somebody's eligible. And if it tells us that they're not eligible, then sometimes we'll consider rebiopsying to see if there's evidence of eligibility that will help us open up additional options for people.
Interesting. Thank you so much.
Yeah, I'm so sorry to leave so many questions unaddressed, but thank you everybody for joining. And Tracy, I don't know if there's a way to copy the questions and I can send
We'll
you
have them.
some answers about general themes to share or something like that. I'd be happy to do that.
Thank you.
Yeah, sure.
Thank you, everyone.
Thanks everyone for attending. I really appreciate it.